Respected professor and
Good
my
evening,
dear
sir.
students, I welcome you all to this RISA online DNB academic activities. Today we have PAT exam questions discussion with Professor Nagasamy sir. Over to Dr. Rishabh.
Good evening, sir. Today I will be presenting the first question, DISC, drug-induced sleep endoscopy. DISC is a diagnostic tool to assess the upper airway of the snorers and OSA patients in conditions that mimic this natural sleep. OSA is a common health problem that is associated with the increase in serious morbidity, mortality, and reduce in the quality of life and higher risk of hypersomnolence. So standard treatment is usually CPAP therapy, which acts as a pneumatic splint that opens the upper airway regardless of the site of obstruction. Indications for DISC is it is used as a diagnostic tool to assess the area of vibration and obstruction of the upper airway. Also performed in sleep disordered breathing individuals, usually done after the polysomnographic study, and also to identify the areas of obstruction. This also helps in the treatment and info on choosing the treatment. Then on patients, OSA patients on CPAP who cannot tolerate the CPAP, they also can undergo DISD. Contraindications is patient refusal, ASA4 patients, and pregnant patients, full stomach patients, and history of drug allergy, suspected drug allergy, what they're going to use. Next. Technique and the procedure. DISC is usually performed in a room which is quite dark and all the basic resuscitation equipments are available, like oxygen, airway card, etc. Usually we monitor SpO2, saturation, ECG, and BIS monitoring may or may not be required. Evaluation of upper airway in light sedation may underestimate the obstruction, whereas a deeper sedation may cause an artificial obstruction due to the over sedation. In the thinnest possible fiber endoscope is ideally with a working channel to aspirate secretions is recommended. The recording for the video and audio is also recommended. Here, the tip of the endoscope should be in the middle of the upper airway, so it do not touch the sides of the walls and trigger the spasm. Time for this procedure is usually 15 to 30 minutes. Position recommended is supine position, where the most of the events usually occur. Then the drugs which we can use is propofol, midazolam, dexmedetomidine, ketamine alone or in combination of all these drugs to achieve the ideal level of the sedation. Ideal drug of choice here is drug which has a shorter half-life, IV or infusions, IV boluses or infusions. This drug should have a minimal impact on the respiratory drive, muscle tone, and the REM sleep. Currently, for the drug of choice used for DISC is propofol. Then DISC versus polysomnography is DISC helps in precise identification, direct visualization of the area, and dynamic assessment of the effect of sleep on airway. Here, only the N2 phase of the sleep can be done, not the REM sleep. Can be induced. Then the tips and pitfalls are it is a NORA procedure. So basic essentials should be made ready. This between 70 to 50 should be maintained. They should not respond to a verbal stimuli and they should not respond to pain. TCI pump may or may not be used. Secretions, mucosal injury, aspiration, or some of the complications we can see. And some degree of obstruction, what we visualize, score of 0, no vibration or obstruction. Degree of 1 is partial obstruction or vibration. Degree of 2 is a complete obstruction. Challenges what we can face here is no oxygen supplementation, no Goodell's airway, no anticholinergics, aspiration risk, mucosal injury, and triggering the spasm. Then it is also a daycare procedure. So we need to titrate the doses accordingly. And also there can be a nasal bleed, laryngospasm, hypercapnia, and there can need for intubation can also arise, and desaturation, which also a common event can occur. Coming to propofol, which is ideal drug of choice we use for DISC. Manually, injection boluses of 1 milligram per kg can be given, followed by 20 milligram IV boluses every 2 minutes until the start of snoring apnea cycle. When coming to TCI pumps, there are two techniques, slow technique and rapid technique. Coming to slow technique, target the propofol plasma concentration of 1.5 microgram per ml, increments of 0.2 microgram per ml every 2 minutes until the start of snoring apnea cycle. In rapid technique, here we set the plasma propofol concentration of 2.5 microgram per ml and 0.2 mics per ml increments every 2 minutes. Different classifications has been set regarding according to the type of obstruction what we face. Then other techniques we can induce with midazolam and titrated propofol doses, and dexmedetomidine also can be used with 1 microgram per kg loading over 10 minutes and infusion of 0.2 to 0.7 microgram per kg per hour till the procedure can be maintained. Coming to pediatric cases, same supine position can be maintained. Nasal cannula can be used for the oxygenation. IV line should be secured. We ideally need to vasoconstrict their nostrils using oxymetazoline and 1% xylocaine, which can be done in using cotton plugs. Usually they pass the flexible fiber optic endoscope into the nostrils posteriorly towards the nasopharynx, where they can visualize the adenoids, palate, and uvula. Coming to oropharynx, they can visualize the lingual tonsils and pharyngeal tonsils. Here, scope is also passed under the epiglottis, where the dynamics of supraglottic soft tissues as well as the vocal cord motions also can be observed. In post-op, we need a 2 to 3 hours monitoring, and we need to maintain the oxygen saturation. That's all.
Excellent. Very good. Very detailed and very nicely planned answer. But as usual, the teacher's job is to find some lacunae. So you mentioned that there is no need for, may or may not be, BIS monitoring is useful. But later on you say BIS must be maintained between 50 and 70. So BIS monitoring is very important. It is not that it is an optional monitoring. Okay, based on the BIS only, you know whether the patient has gone for asleep or not. Okay, so that is number one. Point number two, have you heard of VOTE classification, VOTE classification?
Yes, sir. Yes, sir. NOHL or OAT classification. OAT refers to velum, oropharynx, the lateral wall, then the tongue base and epiglottis. And
So,
NOHL classification is nose, oropharynx, hypopharynx, and larynx. I thought it would be extensive.
very good. Oh, but that is a very important point to find out what is the shape of the upper airway. Okay, so based
Yes,
on
sir.
these four observations, the velum, the tongue base, and the epiglottis, and oropharynx, the shape may be horizontal, or it may be vertical, or it may be collapsed, and then the tongue base may sometimes be the one which is preventing and visualizing the epiglottis. So that is a very important point you have to mention. Based on that only you can find out whether it is a mild, moderate, or severe condition. Okay, that's the second point that has to be included in your otherwise beautifully well prepared answer. The third thing is, what are you going to achieve by doing this Dise? You say the indications are mainly because when the patient has not improved with the CPAP or not able to tolerate a CPAP, we go for this. Okay. So after doing DISE, DISC, what are you going to achieve? Why do you want to do that?
Sir, we can identify the exact area of obstruction, and we can can suggest the surgeries like uvulopalatal
that
surgery.
point also has to be included. Okay, so you have to include that answer. What is the purpose of doing this, and what are you going to, how you are going to further treat the patient based on this. Okay, so otherwise you have covered all the points. Anyway, for a visual feeling of